Good morning, good afternoon, depending on which coast you are on or where you are in the middle of the country. Welcome to the Via Positiva, the Transformativa Elders Project. We are delighted that you are here. Happy to have you. The Via Elders Project is part of the Via family of companies. If it's your first time joining us, we're glad to have you here. If you've been with us before, welcome back. This project is designed to bring to you the voices of leaders who have spent their careers pioneering the work of connection with others to health. In the Elders Project, we bring these visionaries to you to share and preserve their experiences and preserve their experiences, knowledge, and wisdom to increase the likely success of clients and the systems that serve them. My name is Chris Erickson. I am the managing director of this project and delighted to be here with you today. Few housekeeping ideas, requests. We are being recorded, so if you are uncomfortable being recorded, please stay muted and off screen, and then no one will know that you are here. I would like you all to stay muted during the dialogue, please, so that we can hear Jim and John in their dialogue. There will be time for questions at the end of the conversation. You can add questions in the chat anytime during the discussion, and we will get to them as we can at the end. There is a CEU available for today's session. I will be sending out an evaluation for those that are attending, and completing that allows us to generate a CEU certificate for you. But even if you don't need a CEU, we would love your feedback. We would love your feedback. So please consider doing that for us. All right. Now I need to introduce you to two very special people. If I can get my slide to move. Come on. There it is. First up, our host for today's dialogue is Jim Clarkson. Jim is the chairperson of the Via family of companies. He serves on numerous boards and in advisory roles to the nation's leading healthcare providers, and previously served as a national vice president with Value Options. While he was with Value Options, Jim was responsible for enterprises in emerging market areas, managed state substance abuse delivery systems, and served as an internal and external substance use disorder subject matter expert. Previous to that, Jim both led behavioral health and substance use disorder treatment provider agencies and worked as a clinician for many years. He provided consultation and training nationally and internationally, including for the United States Department of Health and Human Services, the Substance Abuse and Mental Health Services Administration, the Health Resources and Services Administration, and the Network for the Improvement of Addiction Treatment. Jim has worked and consulted with programs across the country, focusing on the connection between spirituality and wellness, mental health, addiction, recovery, and financial literacy. He managed the Healing Circle at the Institute of American Indian Arts in Santa Fe and has worked with pueblos and tribes around the country. For more than 35 years, he's helped Fortune 500 companies and public healthcare systems create environments for recovery, sustainability, and positive therapeutic options. And I should have said before I started these introductions, I could talk about each of these men for the entire time that we're here. But they need to talk to you, not me. So then we have Mr. John Tadich, who is our distinguished guest today, our distinguished elder. John is a behavioral health entrepreneur and currently the chairman of the board of I Hope Network, a telebehavioral health company that uses a unique approach to cognitive behavioral therapy to produce low-cost, predictable outcomes that exceed current norms. John was previously the CEO of United Behavioral Health and also president of the Public Sector Division and Emerging Markets for Value Options. He had management oversight for 13 state programs that provide behavioral health services for Medicaid and indigent populations. John has more than 40 years' experience in managed healthcare. He's worked in all segments of the market, including commercial programs, health plans, Medicare, and Medicaid. He's been particularly active in the behavioral health aspects of healthcare systems for the last 30 years. John's career has been about developing systems and business practices that are healing for clients and good for providers, insurers, and public sector agencies. That, my friend, is a challenging trail to blaze, and he has been a master at it. It is my privilege to bring John and Jim to this dialogue today. And with that, Jim, I am going to turn this over to you. Jim, you're on mute.
All right. Thanks so
There
much,
you
Chris.
go.
I
There
really
you go.
appreciate that wonderful introduction, and thanks to Dr. Chris Erickson for uh, being the managing director of the Elders Project, and who just always does such a great job. I really want to thank all of you being here for on this beautiful Friday afternoon. I'm in here in glorious Santa Fe, New Mexico, just taking in all the wonder and the mountains and the beauty and the sunshine, and glad to be with you all. Definitely, I think we're really in for a unique experience today in our conversation with my former boss and leader and teacher and mentor, John Tadich. John is one of those people that just has the unique combination of incredible business knowledge as an former insurance executive, a provider CEO, the chairperson of iHope, which was a digital service provider, and much more, as you'll hear from John. So just really appreciate John joining us today, again, as well as all of you. So it's coming up this weekend, Father's Day on Sunday. So happy Father's Day to all of you dads out there. Be also thinking about our dads, some of whom may still be here and some of whom may have passed. Just acknowledging the importance of dads in our lives and possibly shaping the great work that we do in the field. So one of the things we know is that honoring elders and honoring our ancestors can be rich areas for helping to shape and enhance the work that we do. And so we just take a minute to honor our fathers and all of you who are dads, shaping the little ones who are up and coming, hopefully, to navigate healthily this really challenging world that we live in right now. So thanks to everybody, and especially thanks to John. And John, I'm just going to kick off with the first question here, if that's okay.
That is good. Can everybody hear me? Did you hear
Great.
me, Jim?
Yeah, definitely.
Yes.
Sure. Okay.
Yes.
So thanks again so much, John. And I want to just start with our first question here is, you have done an incredible amount for our field of behavioral health in so many different arenas. As you reflect back, I just wonder what you feel were the most important contributions or the most valuable contributions that you've made over these years, and I know there are many.
Well, first of all, I'll say that I devoted most of my attention to the mental health world organizationally in 91. So a lot of changes over that period of time and lots of reasons for changes, some of which we'll get to a little later that didn't work out the way they were intended. But you know, as a manager, I'm an executive, I'm not a clinician. So I just bring kind of a business perspective to this and am influenced by the experts in the clinical aspects of it. But, you know, one of the things I really thought was a great accomplishment was identifying gaps in the continuum of care. And when I was at United Healthcare, as an example, in Milwaukee, you know, we compared all of our sites statistically, and Milwaukee was a big outlier in terms of inpatient days. And, you know, with a little bit of investigation, it was a lack of intensive outpatient programs. And so what we did is sat down with the biggest hospital with the most admissions and say, you know, if you will build an IOP program, we will guarantee you the volume to make it economically viable. And not only as a benefit to United Healthcare, who had an HMO there, but as a community resource. And that worked exactly as we would have hoped. You know, great program, numbers moved in the right direction, and people were being treated at the appropriate level of care. Uh, the other thing, and Jim knows this probably at least as well as I do, you know, when you work with these state Medicaid programs, they have what they call a penetration rate. That's the percentage of the population that actually enters treatment. And, you know, we know that population is um, in greater need of mental health and substance abuse care than your typical, you know, employer population. And but they're also difficult to reach, hard to get into care, hard to get them to show up for their appointments even. So I think we developed, you know, I was living in Colorado, I'm now in Georgia, but we developed a lot of outreach and kind of benefits, you know, transportation and other things to improve that penetration rate. And, you know, when I started in the behavioral health business, 5% of the commercial population typically had a mental health claim. In Medicaid, it was running about 15, but it should be running between 30 and 50%. And through a variety of strategies, we were able to increase that at least to around 30. And I think that's, you know, a critical thing. And then I think a theme throughout all of the things that Jim's involved with is demonstrating the value of mental health to the entire healthcare system. You know, we know people with chronic medical conditions often have comorbid mental health issues, and for a whole host of reasons. A lot of those medical conditions are extremely stressful. Uh, and, you know, looking at the system in its entirety and not looking at mental health costs and medical costs separately, but in their totality. What's going on with this individual and how do we manage their care and their outcomes, you know, really holistically. And Jim, one of the questions you asked me was, you know, when we were exchanging emails is what are the barriers to continued progress here? And I, I think now, I mean, just the news since January 1 is financial to a lot of extent. How do we get the money to do this? And how do we get people to look at the broad picture, not just what are you spending on, you know, mental health or substance abuse, but what are you spending on this entire population? And how do we manage that not only for the best outcomes, but the best outcomes almost always produce the lowest cost, total cost over time.
Absolutely.
So I think that's a huge challenge we're facing.
Yeah, absolutely, John. I really appreciate what you said about how you, as an insurer at that time, you know, were looking for the gaps in service, and made an arrangement with a big hospital there to offer IOP. And I'm wondering if you can share about how that could also happen in the opposite direction, where if providers are doing environmental scans or seeing a certain population that's not getting the appropriate level of care, how they could also potentially make business cases to insurers to address some of those same issues. Did you see that much? I don't know if it happened that much early on, but later on.
I think it's a really good point. It's a matter of being sincere about having a dialogue. We've all sat on these advisory groups, and they're kind of perfunctory. You're supposed to be there. I'm on a couple of those panels.
Yeah.
But to really listen, to what's going on and try and find solutions. In a minute, I'm going to talk about seeking advice from a broad array of people. And you don't have to take it all.
Mm,
Some of them have an agenda, but getting that perspective, I think, is really, really important. And getting some insight.
absolutely. Yeah. Thanks, John. Sometimes people underestimate the power of reaching out and developing those relationships, and I think that's an important point that oftentimes the insurers are looking for those solutions to gaps, and providers can also look for ways to, especially now, maximize revenue when it may be, limited. So tell us more about, John, about your formative years and the influence that have shaped the person that you've become, both personally and professionally, and that shaped your work and your career.
Well, when I was thinking about that, I came out of the University of Colorado in 1975. And back then, it was mostly just group insurance. It wasn't, managed care or any of that. And as part of actually becoming a salesperson, I had to go to Winnipeg because I worked for a Canadian company and train as an underwriter. And most of our underwriting was done manually. I actually plotted
Wow.
the employees on what they called a J rate sheet by age and sex and everything. And then you rated every benefit, from the mental health to, maternity benefits, which back then could be limited. And mental health particularly was limited. The typical benefit was 30 visits a year to maximum, and a maximum of 30 days uh, in a hospital. And so when you price those and you work through these spreadsheets, what we found out is one thing drove a cost in another area. And you got the actuaries analysis of what the incremental impact of certain things was. And then, as I've reflected back and I've started writing a paper about this, what was the healthcare system's response to that? Well, in the 70s and 80s, we got all of these inpatient for-profit systems out there, charters, psychiatric centers of America. And lo and behold, their programs were 30 days because that was the benefit.
Yeah, exactly.
And I started, as I looked at that more and more over the years, it was like, my God, you write the benefit and the programs will be designed around that, irrespective of what the actual patient needs. And it's not that they were necessarily doing harm, it's just that they weren't matching resources effectively with the need.
Right.
So that was one of the things I learned. Um, One of the other things I've learned, because I have one of my family members who's been seriously and mentally disabled for 50 years. I've mentioned her to you earlier. Brilliant psychology degree. Uh, but, you know, she's in the Medicaid system and Medicare, and helping her navigate that is really a challenge. And particularly, and I think this is probably true in many cases, when she's not particularly cooperative. So, it's not just a matter of, you taking your logical approach and saying, well, I talked to a lawyer, I talked to a case manager and all that. It's trying to position it in a way that it'll actually be, you know, followed through upon. And I think that's a big challenge. Uh, and the other thing I've found as a stakeholder uh, is it's exhausting.
Yeah.
And uh, I have four sisters, and because I work in the healthcare industry, uh, basically three of them are like, John will handle this. And it's a lot easier being an executive than it is being a stakeholder sometimes,
Absolutely. Yeah.
where you can make decisions and they ultimately get executed. And I just think stakeholders need more support and a little more empathy from a variety of, resources. But there's a lot of people that have a stake in the game that would just as soon kind of wash their hands of it. And I think that's, a big challenge and a skill to how you bring them in.
Yeah, yeah, absolutely, John. Thank you. It's you probably one of the most knowledgeable people about uh, navigating the healthcare system, really verbalizing challenges on how tiring it is and how difficult it is to even help your own family member. And I can certainly relate. It's like I had a brother who was needing substance use disorder treatment of immediately. And I can't tell you the labyrinthian challenge it was to get him the care. And I knew some of the CEOs of these places, and still it was incredibly challenging. And I'm wondering, from your perspective as a family member, as well as an executive, um, I wonder how, if you've seen any things that might have been more supportive to families, or if there's anything that payers, on the behavioral health side or on the, both physical and behavioral health, working together, or a certain type of care management. I'm just want any suggestions or ideas that maybe might uh, broaden the vision of those of us on the call.
Well, a lot of the Medicare Advantage organizations have gone to kind of um, caregiver respite
Mhm.
and providing some resources there. And I think that's uh, a great acknowledgement that these unpaid people who have a real vested interest in the outcome of, a person near and dear to them, um, but they can use some help. And even if it's just encouragement
Yeah.
and kind of counseling, one of the things I've thought about is, uh, there's an expertise on the clinical side that can be really helpful to you, in dealing with these situations. How do I respond? The weird thing, I had my this sister of mine who's seriously mentally ill. She called me up and announced, I'm starving. And I'm like, how are you starving? You have, food stamps. We're supplying, $300 a month to help support you. But, where she spends her money is not necessarily where it should be spent. And, I could really use some help in coping with that, because my initial reaction is, you are not starving. You're wasting your resources. But it's a tricky environment because you got both the emotional response and then, at least theoretically, I've had this background in behavioral health, and I should be more understanding. But it's harder than I would have ever thought.
Yeah, I think that's really saying something, John, when you say it may be easier to be the president of one of the largest insurance companies in the country than navigating the challenges with your family member. I mean, that really just speaks volumes. And well, we'll get to this question. Well, I actually wanted to ask you, who your mentors were, whether you've met them or not. Like, who are the people who have guided you or mentored you along the way?
Well, that question actually triggered me calling one of my old
Ah, wow.
mentors. He's long retired, living in the desert in California, but I've talked to him periodically. But a guy named John Cole, who had been a executive with Prudential when I hooked up with him in Beverly Hills, of all places. We were working for a hospital corporation that was trying to build a managed care entity, and just saying it was based in Beverly Hills tells you this is not an economic model that's likely to be very good. But uh, he was really a pragmatic businessman. And one of the best things he gave me was that you can be a successful business person and still retain a sense of humor. You don't have to be, manic about the numbers and all of that. Um, there's some things you can change and some things you can't. Learn how to navigate around those other things. And the other thing he reminded me when I was talking with him today was own up to your mistakes. He said with that Beverly Hills operation, he knew going in it was not likely to be a success. And he said, I either should have fundamentally changed the model or refused to go there. And I have to tell you, the CEO of that hospital corporation, American Medical International, his office was bigger than the first floor of my house in Colorado.
Wow.
So there was a lot of money
Wow.
in that business at the time, but of course they're gone now because they didn't adapt.
Yeah, yeah, yeah. Yeah, I love your answer about retaining a sense of humor and really acknowledging the things that you can change, and then there's a lot of things that you just can't change. And navigating that. One of the things I noticed, John, in the meetings that you used to facilitate with your executive team at Value Options was the way that you were absolutely so kind to your executive staff, and no matter what the issue was, treated them with an incredible amount of respect. Uh, Even when you were teaching, you didn't talk down to people. What were some of those characteristics? And I wonder if that was intentional or if that was sort of just your way of leading. But it always made an impression on me when I would be out in the communities and people would start talking negatively about insurance executives, and I would go back to the meetings and that you held, and the people that were there, and some of the kindest, smartest, most wonderful colleagues, and a lot of that was really around the tone that I think you set uh, in those meetings.
Well, the first thing that I think everybody in a management role has to recognize is you don't know everything. And there's lots of expertise. That's why, if you look at the C-suite of a corporation, there's experts in finance. There, in a managed care company, there's a national medical director. And you need to listen to those people. And sometimes they're going to be in conflict because if you want money for something, the CFO's involved, but you got to consider the other dimensions of the clinical impact of it. And I think if you recognize how much expertise is sitting around you there, uh, you just become a better listener and you make much better decisions that way. Uh, and occasionally you're going to have to tell somebody no, but it doesn't have to be in a rude or confrontational manner. I mean, you just need to lay out. And, one of the comments, I made about how do you become better at managing is um, kind of recognize your own limitations and that every day to this day, I'm still learning stuff. I'm reading and finding out things that hadn't occurred to me before. So you've always got to be in learning mode. And I think that makes you a better partner with your fellow um, employees.
Yeah, yeah, absolutely. And that sure came across. Uh, so I wondered if you could give your younger, fresh-faced self just out of college some words of advice or words of wisdom. What might you tell that younger version of yourself as you head out into the business world?
Well, first of all, no matter what role you're in, but particularly as you move up, um, get a variety of inputs. And it's much easier than people think. Uh, if you think everybody's looking to you to know everything and make these magnanimous decisions, you're wrong. But there are so many resources out there. Like, Jim, when we were working with the states, whether it was Kansas or Colorado or New Mexico, um, the State Department of Health was not the enemy. Uh, they had some things that probably conflicted with our priorities and tried to push things, off. But by and large, at the end of the day, they wanted the same thing. We all wanted to get people the care they need, and we wanted to demonstrate that it was working. And I think a lot of times, I don't care what dimension you're running, whether it's state government or you're running a managed care company or a local clinic, um, you don't understand how open people are to helping you. You know, there's lawyers at, in every state government, there's lawyers at all these corporations. And if you're engaged with them under a contract, that's all free advice. You don't have to take it, but you do have to reach out to it. Um, and get their perspective. And it helps you make better strategy, knowing, well, this is the perspective that these people have. And we need to reconcile that somehow. And, uh, and a lot of the advocacy groups, NAMI, um, peer support groups, we've had done work with some really significant peer groups. And they're also a great resource of information and expertise. Uh, you don't have to discover all that yourself. They'll help you and they'll critique your plan. And you don't have to take all of their advice, but some of it is really valuable and practical.
Mhm.
So that would be one thing.
Sure.
Uh, the other thing, and I thought a lot about this because I'm writing this paper on the evolution of health insurance.
Wow.
But look down, look down the road at the unintended consequences of some things that are done. And one of the interesting kind of anecdotes is the first health insurance contract was for a teacher group in Texas. And what it paid was just for hospital costs.
Hmm.
And it actually wound up being the birth of Blue Cross. And originally, I don't know whether people understand this, but Blue Cross was just the hospital portion. Blue Shield was the physician portion.
Hmm.
And well, so they put in this benefit that pays only for hospital costs. And what happens? All the care starts to be delivered in the hospital.
Yeah. Yeah.
Most expensive place possible. And, I think the intention was good at the time, but pretty easy to see if that's all you're going to pay for, then people are going to get care where it's covered. And there's dozens and dozens of examples of that over the history of health insurance. And to providers' credit, they're smart enough to maneuver around policy. If you're going to pay for something, but not for something else, you're going to try and define as much as a covered expense as humanly possible and do more of that. And the other thing that am really concerned about, uh, even though I like some aspects of it, is like value-based care. if you're going to be paid for the entire course of treatment and the outcome on kind of a fixed basis, well, then you want to make sure you don't get those really complex, troublesome patients because they're going to be the outliers. So if you want to look like you're really an outstanding provider, you want to hit all those parameters and maximize your income. And I was talking to a friend of mine who does a lot of contracting in the surgical world, and so much of healthcare now has become procedure oriented. But he was telling me about a surgical group who actually segment their surgeons by contract. If you're on a fee for service basis, if they have that contract, only one group of doctors is going to treat those patients because no matter what goes on, they're going to be paid for every encounter. Whereas if you're on some sort of a global value-based payment scheme, you want those docs focused on patients that have a really high prospect of having a good outcome. And that's scary because sometimes the best docs are the ones that are getting the least complex patients because financially that makes the most sense. And that worries me quite a bit that we,
Yeah, absolutely.
segment populations that way.
Yeah, it seems like you're really getting to like a really important question, John. It has to do with the drivers, the drivers of insurance companies, the drivers of public sector, regulatory funders, CMS, SAMHSA, the others, state general funds, peers, clinicians, how there really seems to be different drivers in many of those. And I'm just wondering, here, even on this call today, we have, former CEOs of insurance companies, and we have regulatory funders, and we have clinicians and psychologists and peers. And, as you're talking, I'm just wondering how can we shift from being motivated by quarterly profit reports and the like to something that might be more uh, communal or more equitable? And I know that's a hard question, and there's no easy answer. But your comments about developing relationships among the stakeholders, I think, really for us, for at Via Positiva, that's what we found is the sort of the secret sauce. And now I'm hearing you say the same, similar thing. And I'm just wondering if there are any other thoughts that you might see that would really help blend these what sometimes competing drivers might be.
Well, just a little bit of background. One of the challenges of behavioral health, and particularly the evolving payment systems, is that everything has come out of the medical side. And, it's much easier to get definitive data. You get a diagnosis of cancer, you have procedures, there's a really series of steps that are measurable and outcomes that are measurable. Not so easy in the mental health field. Literally every patient is somewhat different. And trying to apply these algorithms to mental health is much more of a challenge. And, people need to recognize that. Uh, and we need to figure out better ways of dealing with that. Um, and there was another part to your question that I've just forgotten. So I think,
Yeah, just I think if there were any suggestions on how we might be able to bridge some of those different paradigms or different drivers. And one of the things I'm hearing you say is even though outcomes on the medical side are more easily measured, oftentimes they have many more years of implementation around outcomes. And on the behavioral health side, it's not so cut and dried, but it's important. It seems like that's what I'm hearing you say is one of the things
Yeah.
is we do have to have those measurable outcomes. And then also, and I know we've got several people on the call that have actually done this, and that's set up client distribution processes on the Medicaid side where the health plans can't cherry pick, that they're just essentially assigned. Um, and so anyway, just curious about that whole, me, I'm always trying to blend these to find that sweet spot and see where sometimes I feel like I'm too optimistic, but I really want to keep moving in that direction. Where do we overlap? Where can we adjust? Where can we find common drivers and common outcomes? So,
Well, and I think at the end of the day, it's about really treating people holistically, treat the whole individual, and recognize that, mental health is a huge driver of medical expense. So many people that wind up in the ER are there because something psychological is going on. They may be having a physical manifestation of that, but the real trauma may be occurring elsewhere. And I wanted to mention one thing. When I was at United Healthcare, we had a company called United Resource Network, which was run by a brilliant guy, but he reported to me. And United Resource Network was the organ transplant centers of excellence.
mm,
And one of the beauties of organ transplant is that it's probably the most documented procedure in the history of the world. Who's eligible, what's the ideal match in terms of a organ, um, and they measure infection rates, retransplantation rates, life expectancy afterwards. And it turned out that Stanford, Northwestern University, University of Nebraska, a number of these medical schools and hospitals, while they were expensive, were actually the best and cheapest uh, group you could contract with because people lived longer, they had fewer complications. Um, it was amazing because, I remember, and I won't mention any of these hospitals, but they had programs. And when you factored everything in, you could go with the best
mm,
and you could afford it. And the patients benefited from that. I mean, who would say, I don't want to go to Stanford?
mhm, mhm.
It was just amazing. And we need to think about things in that way, that uh, the per diem isn't necessarily the measure of quality and outcomes and total cost.
Sure. Yeah, absolutely. Great points. I just would love to, think about that measure in terms of behavioral health best practices. Like where are we really showing outcomes? What is really the definition of the best? Uh, yeah, it's a great question and a great point. How the physical health providers have that you all saw that was so important. Uh,
And when you think about it, Jim, there's a lot of cost elements that we don't consider in the healthcare world, like keeping somebody stable and productive and in the workforce. We don't get any pay for that
mhm,
necessarily, but that person could also be, on a state or federal subsidy when they could be working, making a contribution, and probably far happier, having a life. And that's a benefit of getting good care.
yeah,
And, there's tons of examples of that. I mean, amazing numbers of people that deal with their mental illness and still become productive members of society. And that kind of global view, I think, is important.
yeah, absolutely. Once again, you're circling back around to these positive outcomes as oftentimes the most economic outcomes over the midterm or long term, and how important making that connection is, because I feel like that's where the sweet spot where clinicians and payers and providers and regulatory funders, that's sort of what we're looking for, is that sweet spot that brings those, positive outcomes. And also really, as you mentioned, identifying, what are the social determinants of health that are challenged, what care for the caretakers is, really important, and what not only kind of what we do, but how we do it. Like, what's the quality of the relational piece between care managers and the relationship between utilization management and providers. And so one of the things that we're always thinking about is how do we raise that quality level, not just of the what, but of the how. And I feel like you and others really set the tone in the work that I've seen you do within the systems that you affect by having that quality of relationship and mutual respectfulness and not knowing it all. Because a lot of providers that we see across the country, John, as you know, and peers and clinicians, et cetera, are hesitant to outreach to the attorneys, like at the Department of Health, as you mentioned, or the insurance companies, or the regulatory funders, et cetera, because they seem so big and so monolithic, and oftentimes come across as knowing it all, and so
Inflexible.
rules based. It just seems like an important focus is the relational piece.
We're going to reach I think, the Q&A here, but there's a couple points, Jim, that I wanted to make. That one, when it comes to technology, one of the books that I would recommend people read is, let's see, well, I'll find it in a minute and we'll post it. But, I think it's important we use technology to augment, not replace clinicians. And I think it has tremendous value if it's deployed properly. And I consult with a couple of companies, but I think that's important because there's a sense that, Headspace and some of these companies, you can do it all online. You can self-treat. And I don't have much confidence that that's possible. So I'd be careful around that. But I think the biggest challenge right now, and it's going to get bigger. I mean, I think, the recent healthcare events in the country have driven a lot of mental health stress and anxiety. But I think now there's more animosity, more friction, more stress in our society than ever in my lifetime, including through the Vietnam War. And at a time when we're actually losing clinical capacity. And we have to do something about that because things don't get better unless they're addressed, particularly, I think, in the mental health field. And that worries me more than anything, that we need to get benefit sponsors, payers, and clinicians all on the same page and working, towards this. Like, I look at Florida, and these stats are a little out of date, but, in Florida, a psychiatrist could get about $300 an hour for a self-pay client. He could get $160 for a Medicare client, and he could get 60% of Medicaid, or 60% of Medicare as a Medicaid patient. Well, if you've got a practice that's overwhelmed with demand, you're going to either go with high-paying insurance companies or, self-paying patients. And it's creating this enormous desert of need in a lot of the segments of our society. And that is really bad. New Mexico's a good example of having areas that are, devoid of any psychiatrists, and many states are there. And New York City Council declared a mental health emergency in their state. They think they're 40% short of clinical capacity there. So that's probably one of the biggest challenges we face.
Yeah. So in your entrepreneurial spirit, John, if you were looking at proposing solutions to these challenges, what would be some of the things that you might be looking at if you were, say, a provider on this call and we're addressing the things like the emergency declaration in New York City, issues with migrants, issues with homelessness, all just the myriad of people who are in need of behavioral health services. How might you look at that?
Well, first of all, we have to pay them appropriately. And when you get budget cuts like LA County is now facing, LA County spends $2.9 billion in mental health and substance abuse care, just one county on mental health. So, when they get a budget cut, that can't filter through to the providers who are already poorly paid. You got to figure something else out. And, I look at some of these RFPs like that one in LA, and part of their solution was, well, we're just going to offload these expenses to, some managed care company. Well, they're not dumb. They're not going to just wade into a contract where they're going to be paid, half of what they project will be the cost. So we've got to do something about that. And then we need to make clinicians more productive. My psychiatrist friend I worked with for years, a guy named Brian Gould, but he's also a techie. And he said, healthcare is the only segment of industry where technology has made us less productive. And by that, he means people are spending less time face to face with patients because they got to fill out all this stuff for, electronic health records. They've got to be, making sure their value-based payment system is documented. And it's a huge burden. Just on the primary care side, my primary care clinic in Fort Collins, when I was living there, was Associates in Family Medicine. Citywide, great group clinic. Then they were acquired by Walgreens. Then they were acquired by Village Medical. And every time the technology changed, but they locked up the providers for 3 years that you couldn't get your equity out of your practice. That expired January of this year. 38% of the doctors left. We cannot continually burden clinicians with all of this documentation and other stuff. It's important. We want to track, we want to make sure people get good care and that we're doing the right things. But we got to figure that out.
Yeah.
The clinician needs to focus on the patient, not on meeting some, algorithm that they know is going to determine whether they get paid or a bonus or whatever. I think it's just become too administrative, and a lot of docs, are frustrated
Mhm.
and don't want to do it anymore.
Yeah. Yeah. It's remarkable that focus on medical loss ratio as that increases, that denials oftentimes increase, and that just seems like such an unethical way of determining clinical care. And yet I know that it's sort of standard operating procedure at some of the insurance companies, and I really hope that, as you're saying, that there can be some equity sort of across the board with providers as well as payers and clinicians, and certainly peers and care managers as well. Do you have any comment on that before? We got a lot of questions, so I'm going to.
Yeah, I know. Now the one thing I did want to say is, there's this thing called a single service agreement, or they have a lot of names for it, but a lot of providers think if a payer denies you or you're out of network, that you have no alternative. Um, you can actually talk to a payer and for a specific patient, get a contract. You're not a member of their network or anything else. But I did this for a friend of mine who had breast cancer. And the only place she could get the particular course of treatment that she felt confident in was at the Mayo in Arizona. And my employer denied her claim. But I talked to the medical director and explained some of the psychological dimensions, and they cut a contract with the Mayo, who doesn't contract with payers, for that particular case. And the Mayo accepted it. She got her care there. She's 16 years post this cancer treatment, and she's doing great. So a lot of providers aren't aware that you can even do that. But it's worth understanding that process, particularly when it comes to really high-end kind of care.
Absolutely. Yeah, great point, John. So we've got a lot of questions, so I'm going to turn it over to Dr. Chris Erickson, and just a personal thanks again, John, for all you have done, all you're doing, and for being with us today. I hope we can continue these conversations, and some great questions came through. So let me turn it over to Dr. Erickson, and Chris, it's all yours.
Thanks, Jim. I would have loved to work for you, John. Just saying. Just saying. I would have loved to have worked for you. So here's a first question. Can Mr. Tadich reflect on how he feels the systems of care have or have not pivoted to demonstrate inclusive treatment options for various disabilities, such as hearing, sight, physical access, and so on, under the ADA, and as the specialized needs of individuals may increase to a greater degree with aging clients?
Well, a lot of, particularly, state and federal programs mandate a lot of that kind of access stuff. So I think there's, and I haven't personally used it, but I think there's, some accommodations that have been made, and they're hopefully pretty effective. But I think there are subpopulations that have very different needs than the broader population. And working through solving those, I think really is something that requires a lot of input from the different stakeholders, from family members to providers to payers. And again, looking at the total cost and outcome for those folks by providing some of these things, maybe that are even completely outside of the insurance language. I used to do that back in my group insurance days. We could get exceptions when a particular case required, really a specific accommodation. So I guess be my comment on that.
All right, I'm gonna build on that, because what I've experienced, and this is personal, what I've experienced in this world with exceptions in 2025, 2024, 2023, is they're hard to come by. So how do you, if you're a client, how do you engage with, or who do you engage with at your insurance company that can start to help you find that exception?
Well, you have a member line. That's the place to start. I'm sure a lot of people aren't very satisfied with just calling member services, but it's a good place to start. And I think before you go to them, you ought to make sure you have your facts in order. And that may be talking to an advocacy group and getting some perspective and some advice, and the key words to use when you're talking internally with a customer service line or something. I think we're all finding customer service lines are extremely frustrating these days with wait times and with the level of expertise they have. There's so much that's just, on their screen, and that's the limit to it. So getting around that, I think, is a real skill. But your your clinician can help. Um, some of these state agencies can provide some input, and you just got to be really resource aware. And it's not just what's on your ID card.
Thank you. Appreciate that. Here's a question. I'm interested in John's words of wisdom about how to best make job role transitions. What were your favorite tools when deciding which roles to move to and from in your career?
Well, interesting question for me. When I was at United Healthcare, I came in there to run their small group operations, small employer insurance. And I got drafted into the mental health subsidiary. And when the CEO of United at the time asked me to take that role, I told him no. I don't want to be involved with that. Those I know nothing about it. Those people don't get better. It's very problematic. I don't want to go there. Well, I wound up going, and it was a great career decision in 1991 because it's been one of the highest, you know, uh, topics of conversation and needs uh, in the healthcare world. So I think you need to look at trends, um, and as you plot your career, the things that interest you. And in my personal life, I had an interest, uh, in behavioral health, which helped mitigate the business aspects were a worry to me. Uh, and I was really fortunate because this Dr. Brian Gould that I mentioned earlier, um, he really explained to me the opportunities in the mental health and the need for better organization there, which were the kind of skills that I was bringing. So you just have to be aware of what's happening. And California healthcare right now would be a scary place to be. I don't care where you are. But that's going on in many, many states with these budget cuts and other things coming through, and figuring out, who are going to be the least negatively impacted by that.
Sorry, I have to remember to unmute myself to be able to read you a question. And I'm skipping around. So here's one. In your opinion, to what extent and how, potentially, can peers, community health workers, and other similar positions be leveraged to address the clinical shortages that you described?
Well, I'm a huge believer in peers. Both Jim and I have a longtime associate, Clarence Jordan,
Mhm.
who does training, and I think the level of expertise among peers is growing, and they have the added advantage of really unique insights to share with patients, and uh, there's a lot more of them out there. So I think that's a really valuable resource that we need to emphasize more. We need to make sure the payment systems support that kind of care. Um, so that's one. Um, the overall system, I think, is kind of in a crisis, and it's going to take a lot of smart people to figure out how to solve that. But I think we as a country probably need to have that as one of our top priorities. Uh, that we can't continue kind of down this road of decompensation almost, uh, and expect that we're going to be fully functional and peaceful.
Do you think, John, that commercial programs are willing to pay for peer supports and advocacy and things of that nature? I mean, we talk a lot about Medicare and Medicaid because many of us on this call are involved in that or have been involved in that almost exclusively for our careers. Do you think the commercial payers are interested in that?
Yes.
Okay.
They're interested in it as long as you can demonstrate an ROI, return on investment. And that's how you need to present it to them. But, they've been providing EAP programs in the commercial world forever. Headspace and some of these other startups that are actually quite large now that provide, a lot of telephonic and online stuff. They're being used by some employers to, and hopefully to augment their overall healthcare plans. But yeah, I think if you present it right, and then this is one of the interesting things about making sure you get a wide circle of people that give you advice. Like if anybody on this call is in a situation where they want to talk to an insurance company, United Healthcare, Humana, one of those, I would be a good resource because I know how to talk to those people. Uh, not from the clinical perspective, but from an ROI and from a PR. My old employer, United Healthcare, is getting a lot of bad press these days for some of the things they've been doing to gross up their Medicare fees and things, from the government. And it's helpful to understand what management is emphasizing internally there. And I think you can get solutions.
Thank you. Certainly appreciate the thoughts very much. So here's another, wait a minute, hang on. I was on a question and another came in. What are your suggestions for bringing behavioral health services to those experiencing homelessness? And what combination of services need to happen to make it easier?
Well, that is one of our greatest challenges, I think, in the country. A lot of those people do not want to get into care. And, how do you engage them? Um, and I don't really have the answer to that. I've read a number of studies and rousting them. One of the things that a lot of the shelters, don't want you to bring drugs or alcohol into the shelters, and partly as a consequence of that, a lot of people just aren't going. And they say, well, if they get in the shelter, we can engage them, but we need a different approach. Um, uh, they're at that stage, they're not apparently ready to give that up. And the Aurora, Colorado has been in the news. That was where they had all the gang members, and Trump was making a big issue of it. But the mayor there a couple of years ago uh, actually went and lived in a homeless camp for a couple of weeks to try to figure out what what are these people seeking and how can we help engage. And what he concluded was that more than 80% of them don't want to go into a shelter. So somehow we have to figure out how do we break that mindset.
Either that or how do we bring services to them outside
Yep.
of, and that's one thing, and this is a personal thing for me, John. I don't think we have figured out how to bring services to the homeless communities. And living in a rather large city, that homeless community is significant. But we still, in the behavioral health system, seem to think they need to come to us instead of us going to them.
Yeah. And frankly, us going to them is probably the only way that
Yeah.
anybody's going to get together. So, we need to just recognize that. And it needs to be a very thoughtful, strategic approach because if they're not happy to see you, how do you engage them? And, we all have lots of examples of that. I know a young man who's homeless, but has tons of family resources, but just won't take advantage of it. He has a lifestyle that he apparently thinks is a bigger priority. And it's kind of inconceivable to most of us, but that's how he lives, you know. And the likelihood, and there's lots of examples of this, he's going to wind up dead. You know, his behaviors are life-threatening.
Dead and early.
Yeah.
All right, so here's another population question for you to expound on. How can systems, payers, Medicare, Medicaid, commercial, I don't care who they are, begin to really focus on the part of our population that continues to age at a dramatic rate? So we're talking about us, John. We're talking about the baby boomers. We're talking about the fact that we are growing exponentially every year and will be for another 30 years. And there's a lot of behavioral health needs in that population, as well as healthcare needs, that I'm not sure we're ready to address. So, some thoughts on that.
Well, one, I think the view of medical care for the real frail elderly is changing. And I talked to my young daughter who's 38, and she works in healthcare in the hospital. And she works around a lot of patients that, have no prognosis for coming out. And her view, and I think it's probably true of her generation in general, is why are we wasting all of this money? Let's keep these people comfortable, but let's move to hospice, I think, sooner than some of us. And I think that's a part of it. It's when you're in that generation and you're not ready to go, it's kind of scary. But and then the the services, you know, I kind of like that, United Healthcare, who provides my Medicare Advantage plan, will send a nurse practitioner to my home. Uh, and that came out of a program years ago in 1990 when I was with United that was called Evercare. And what they did was they put a nurse practitioner into nursing homes. As long as they had 35 patients in that nursing home, they would put a nurse practitioner there full time. And it was remarkable what happened. One, they were able to start IVs and other stuff, but they had expertise. The general quality of care in a lot of nursing homes was not good. And what we found was that among our Evercare population, the number of days per thousand in the hospital, which is a measure of, hospital utilization, dropped by 50%. But the thing we never thought about was just by having a nurse practitioner there on a full-time basis, she made everybody better because the other healthcare, workers had somebody to ask. And our nurse practitioners were willing to help and do whatever. And they got a 25% reduction in hospital days for non-Evercare patients. So I think there's a lot of services we can provide to seniors if we do it early and we do it realistically. And a lot of times, I've run into this when I was running Medicare Advantage plans for United in California. And a lot of times it's the children of the seniors that are demanding all this care. Uh, I had a woman who was 70, her mother was like 95, and she wanted a particular heart procedure done on her mother, which, everybody said that's not appropriate at her age. But, she got a lawyer. We wound up being forced basically to do this procedure, and she died within 3 months. never came out really out of the anesthesia. Um, so I think, a lot of care decisions are being made on behalf of seniors, and we need to get our arms around that and communicate better with them.
Thank you. John, I know we're at time, but I have one more question that I really would like you to speak to, if you have a couple more minutes.
Okay.
Okay. Can you speak to the advantages, disadvantages associated with a health system that is heavily dependent on employers?
Well, it's a major part of our whole employment compensation. And, they obviously have younger populations and stuff, and uh, the payment system is good generally for those employees. So it's had a tendency, I think, to skew certain provider organizations towards that and away from, Medicare and Medicaid. So uh, you're seeing more employers providing post-retirement benefits, which I think is a plus. Um, but I really have not been overly concerned about the influence that employers have on the healthcare system. Large employers, self-fund their claims. They may have United do, the administration, or Humana, or some third-party administrator, but they pay the cost of all those claims. So they want, you know, consistent, good care for their employees. But I don't think they negatively, impact the healthcare system. Our real problem, I think, is with state and federal funded programs, and making sure they're adequately funded and rationally designed. Jim had asked me a question when we were exchanging emails. Every time you change governor, you shouldn't have a complete change in your healthcare strategy at the state level. That's got to have much more longevity to the planning, because jerking around and adapting to a completely new financial scheme is just not possible, particularly for that population.
Thank you. Thank you not only for that answer, but thank you for the entire dialogue today with Jim. Jim, thank you as well. I so appreciate the two of you and your sharing of stuff, and you're willing to talk to people. And if anything else comes up, John, from the chat and conversations that other people have questions about, is it okay if I reach out to you?
Absolutely. And they can reach out directly. I have no problem at all with that.
Okay.
And I'll reach out to them because there's a lot of expertise out there.
Very good. Well, thank you so much, very much,
Right.
on behalf of myself and the Elders Project and the entire VIA family of companies. We appreciate your time today and your wisdom.
All right. Thank you.
Thank you so much, John.
Yep.
Bye, y'all.
Thanks, Jim. Bye.